session, we have Dr. Rosmy with us. She is an assistant professor in the Department of Medicine, Lady Hardinge Medical College. Over to you, ma'am.
Full session, and I'll just not take much of your time because I know post lunch sessions are about the metabolic disorders. To run through the slides, I'll just be talking about a few metabolic disorders. All of you will be well aware of it: diabetes, dyslipidemia, obesity, gout, and metabolic syndrome. So, why diabetes? We know what diabetes is. It is nothing but an abnormal carbohydrate metabolism. So why do you want to know whether it is abnormal or not? Just because it manifests as a raised blood sugar and it is the talk of the town. Every other person living next to us, the moment they know that you're a doctor, they want to know how to treat diabetes. Somebody in the family will be. And in our families also we'll have more than one or two relatives who are diabetics. So such is the burden of the disease that it is important to talk why diabetes is the most important, the first thing on my slide, because the number of adults in India, they in 2024 it was 89.8 million. Such a big huge chunk of our population is diabetic, and the problem is it is from the age of 20 to 79 years. They are the most productive years of our life, and somebody dealing with a disease which is chronic, which is going to be there with you for your life, which requires treatment, it is a tedious task to make a person understand and to follow a strict regimen of drug as well as diet. So that is the importance of knowing the metabolic disorders and trying to nip it in the bud, or rather slowing or decelerating the rate at which the disease is going to cause a damage. So how do we say, or when do we say that the person is diabetic? We all are well aware of it. One of the ways is getting an HbA1c test done, and the value more than 6.5% tells us that the person is a diabetic. Or the traditional way, which it is easier and probably available at smaller centers or PHC level also. Even in small clinics also, we can easily get done a blood sugar level, cost effective and easy to be done. And a value more than a fasting value more than 126, more than or equal to 126 milligram tells us that the person is diabetic. Now on the slide's very first line, which is highlighted, it is written, it is non-pregnant individuals. So there is a difference in diagnosis in a pregnant individual. It means that. So I will come to that also. And do we always need a fasting blood sugar value, or you always want a HbA1c value? Now that is the question. For example, if somebody comes into an emergency room in coma, do you want to wait to diagnose diabetes? No. If somebody is having a random blood sugar value more than 200 and has landed with any complication, for example, a diabetic coma, diabetic ketoacidosis, or a hyperosmolar coma, then you need not wait for an HbA1c or a fasting blood sugar levels. Or if somebody is having a random blood sugar value more than 200 and he or she is showing a symptom of hyperglycemia in the form of polyuria, recurrent infections, impaired wound healing, then that is also diabetes. You start your treatment, you can very well send the investigations, no harm in doing that, but then you do not wait for them to be diagnosed diabetic. You can very well write down that the person is diabetic. Now, of all these things, what do you do for a patient? What is the importance of getting a fasting blood sugar or an HbA1c? Which is better? So acutely to diagnose, for one single value you want to take a fasting sample, you can take blood sugar levels more than 126, very well a diabetes patient. The importance of this is, the problem with this test is it has to be sent to the lab as early as possible. So pre-analytical errors can happen if the sample is not sent on time. Or if not sent on time, then it should be preserved in ice, or it should be put in a cold, in a refrigerator. And it will be affected by the timing of your food. So you to take the fasting to diagnose on the basis of a blood sugar, you need the person to be fasting at least 8 hours. So meal will affect. And similarly, any stress or intercurrent infection, your blood sugar values will fluctuate. So any stress, it can increase or decrease depending upon. So fasting blood sugars limitations are these. However, for a chronic long-term thing, you can take HbA1c. it is not dependent upon the fasting, or it has no relation to the meal. And intercurrent illnesses and stress will not be affecting the value of HbA1c. So if look at it, this seems to be a better test, but there are fallacies and shortcomings of this test also. As I mentioned, non-pregnant. The slide says non-pregnant. So in pregnant, you cannot use this because HbA1c is nothing but glycated hemoglobin. So in this, you are talking about hemoglobin. So hemoglobin bound to the glycosylated substance. So in such a scenario, the life cycle of the RBC is important. So we all know the turnover of, or the lifespan of the RBC is 120 days. So that is 3 months. So we do an HbA1c every 3 months. So somewhere if the life cycle or the turnover of RBC is faster or lesser, then that HbA1c becomes fallacious. Where do we have such a scenario? In hemoglobinopathies, for example, thalassemias, and there are many other hemoglobin variants. In that scenario, HbA1c cannot be a good test. Even in a pregnant patient, because the cell turnover is higher, so the lifespan will reduce. So that does not become a very good test in diagnosing. In such a scenario, we go in for an OGTT and fasting blood sugar levels. Apart from that, iron deficiency anemia will affect our HbA1c values. It can be fallaciously low in them, and the moment you correct it with iron, then it improves. So relying only on HbA1c becomes a bit difficult, and the cost of the investigation. And probably will not be available in smaller centers or in clinics or in PHCs at PHC level. Nowadays, I think even PHCs are offering the test, but still, so the cost will be a hampering. So now we know how to diagnose. So whom should we diagnose or whom should we test? So the ADA has given a questionnaire. We have to we start filling this questionnaire, and if at the end of this thing we find that the score is more than 5, then probably for such a person, you will want the person to visit the physician and go get himself evaluated. So the questionnaire has got some 7 questions. So according to your answer, we get the marks. So the first question is, how old are you? Or what is our age? So age is going to affect less than 40, 0 point. And 40 to 49, 1 point. 50 to 59, 2 points. 60 and above, 3 marks. Okay, 3 points. Then comes whether a man or a woman. So I think Sashakta woman hai, we all. So women get a 0 point. Men score higher. They get a 1 point. Then if you are a woman, you have ever been diagnosed with gestational diabetes. So if somebody has developed diabetes during pregnancy or hyperglycemia during pregnancy, then it is advised that post-delivery, 4 weeks to 12 weeks later, they should again get themselves tested to see whether the blood sugar levels are high or not. And if it remains normal, but that woman should be in lifelong, she should keep screening herself because they are at a higher tendency of developing diabetes. So that is why this question is important. Then if parents are having diabetes, first degree relatives, that is what I am trying to tell. It is not for type 1 diabetes because type 1 is an autoimmunity condition. We need not inherit it. But type 2 disease, there is a chance, there is a concordance that if father and mother are diabetic, then there is very well a chance that the child will develop diabetes probably a bit earlier than the parents. So that is why the importance of answering this question. And if you have ever been diagnosed with blood pressure, the moment I say this, we should understand all metabolic syndromes go together. They are like finger in glove. They are hand in hand together. You cannot leave diabetes alone and say that there will be no diabetes, but he can have hypertension. They all are together. Somehow the pathophysiology and the diet and our lifestyle will add to everything. So the question here is also whether you have a high blood pressure or not. You get 1 point for that. How much you are, whether you're physically active, how much is not a question, whether you are or you are not. So if yes, then also you get a point. And what is your weight category? On the right hand side of this thing, according to our height, they have given weight which is normal. So 1 point if it is within normal, 2 points and 3 points. And at the end of it, when the score adds up to more than 5, then probably we all should get the person sent to be evaluated for diabetes. So once we diagnose diabetes, now the treatment starts. The only different thing which is happening now, like when earlier it was said that once you diagnose, you add one drug, wait till the blood sugar falls. You have called the person later for a follow-up after 2 or 3 months. If the blood sugar does not improve, you add another. So it was step-by-step addition. Now what the difference we are having is, they say hit hard and hit early. So you don't wait for just one drug, you can add 2 drugs according to the glycemia level and start treatment not just on one drug. More drugs can be added on the very first go. So that is the difference. Otherwise, tighter blood control, sugar control is advised for younger people. In elderly, tighter blood sugars are not advised. For example, we want a fasting to be 110 and a postprandial to be 140 for somebody who is 40 years or 50 years of age. But probably for at 70 or 80, I will not say that 110 is what I want. I will accept a 120 fasting, because hyperglycemia is damaging, but hypoglycemia is life-threatening. So hyperglycemia will produce damage. We all know we can treat it. We are treating it. But hypoglycemia can be life-threatening. And somebody, if he has a hypoglycemic attack, then there is recurrence if you are having. Then there is something called as a hypoglycemia unawareness. It is an example of an autonomic failure. So if that happens, autonomic failure means body is not realizing that it is having low sugar. So initially, when we all know that when we have low sugars, we are jittery, we are irritable, there is palpitation, you are sweaty. In autonomic failure, once you will have it, and if you keep having it, then those symptoms will reduce. So the body's alarm system is off for you. So that is why hypoglycemia should be prevented. So in such a scenario, in elderly, we can relax a bit, but that does not mean you give complete relaxation. The goals can be, it can be standardized according to, or we can tailor it according to the patient's need and age and his comorbidity. So that is importance of what we treat in diabetes. Earlier it was saying ki do a stricter control, but with age and with the patient's profile, you can decide the glycemia level. At 70, probably I don't want 110. I don't want him or her to go into a hypoglycemia or an hypoglycemic unawareness. And it is said that once a hypoglycemia occurs, you should do such strict monitoring that for the next 2 weeks, the person should not land into hypoglycemia. There should be no more events. So that is what is important. Then on to the next slide. Next disease, I don't want to go too much detail into the drugs, but what I want to tell you about dyslipidemia is why it is important. Diabetes itself causes dyslipidemia, and dyslipidemia also individually also it is occurring. So what do we mean by the term dyslipidemia? To identify it, it just tries to tell us that there will be an elevated LDL levels. Our normal is 100. Anything beyond that is a dyslipidemia. Low HDL, we mean to say less than 50 in a woman, less than 40 in a man, and a triglyceride more than 150. If this is what you are looking at a dyslipidemia. Why this concession for, why such consideration for man to have 40 and women to have 50? That is because till pre-menopause, the estrogen plays a protective role. That is why in a woman we want it to be a bit higher. After menopause, this thing will be all same for the man and the woman. Okay, so why do we want to know about dyslipidemia in the Indian context? This is because it is said that the Indian population develops dyslipidemia a decade earlier than our Western counterparts. So we are at a higher risk at a younger age. And the comorbidity and the mortality that is arising out of this dyslipidemia is bad in us. That is, if we look at MI or the heart attack incidence, it is far more in younger generation. We would have read about even young doctors dying of heart attack all of a sudden, peak of their health, prime of their life, and all of a sudden we are losing them. So that is why in Indian scenario, we have dyslipidemia at an earlier age. So the importance of knowing about dyslipidemia plus MI, myocardial infarctions at the age of 40, it is higher among Indians. And another important thing is all the risk calculators for ASCVD, that is an atherosclerotic cardiovascular disease, they all take age into consideration. But these calculators, for example, ACVD risk calculator, the JBS calculator, they are all age-based, developed by a different population. So according to them, a higher age will be more damaging. But here we are finding that younger people are getting dyslipidemia. So that is why there is a difference in dyslipidemia in Indian context as compared to our Western counterparts. Okay. So before labeling dyslipidemia or to identify a category, we need to know whom to put in which category or what are the risk factors. The most important, the blue one, the major risk factors. So what are the major risk factors? 4 things we need to remember. One of them is age, as it is already mentioned. Man more than equal to 45 years of age, a woman more than equal to 55 years of age, somebody who's smoking. So cigarette smoking or tobacco chewing. So I do not smoke, patient will say, but I am chewing tobacco. That the person will not tell. Even if we ask history, people will tell the same. Oh, no, no, no. I am not smoking. Do you chew tobacco? That I do. So the thought that only smoking is damaging is wrong. Chewing is also damaging. So tobacco is also a risk factor. That is why it is highlighted. High blood pressures and a low LDL level. These are the major risk factors for ASCVD. Then is the high risk feature. So family history of premature ASCVDs, young person, somebody in the family in 40s having a heart attack, then the person is also at risk. So that becomes a high risk feature. A CKD, kidney diseases are associated with dyslipidemia, and one of the most common causes of mortality in a kidney disease is atherosclerotic disease, or a coronary artery disease is the most common cause of death in a CKD. So that is why stage 3 and stage 4 CKD. Then an apoprotein B more than 130. Then extreme elevation of any single risk factor which is mentioned. Beyond, if it is high, it is not important. More, it is very high. So that also becomes a high risk feature. Then metabolic syndrome, non-alcoholic liver disease, I'll talk about this. And this is a coronary artery calcium scoring 1 to 99 or 70, less than, if it is 1 to 99, that itself is a risk. As the score increases, risk keeps increasing. Then other risk modifiers will be a lipoprotein A level. It is said that once in lifetime lipoprotein A level can be done. Need not be repeated every time. It is a genetic, it predisposes genetically. Then impaired fasting glucose. So if my blood sugar is normal, I'm very happy. No, if it is more than 100 and less than 126 or you are a pre-diabetic, you are still at risk. So lifestyle intervention will have to be done throughout. So just because I'm not diabetic by 126, my sugar is 125, I'm happy. No, I'm not happy. I have to bring it down to 100. It means to say pre-diabetes is also a risk factor. Then increased waist circumference. Okay, so we all are healthy people and we love feeding every other person. So when I was a student, my teacher used to say, if you want to harm somebody, do it with love. Feed them sweets. So that is what they are trying to tell. We feed well and we are all circularly endowed, so that we have to reduce. That is what it is trying to tell. So waist circumference more than 90 and in men and 80 centimeter in a woman. Then HSCRP, that is an inflammatory marker that tells that inflammation is high, so more than 2. And plasma triglyceride level. Diabetes per se causes hypertriglyceridemia and LDL elevation, so it is a marker here. Then rheumatoid, all these connective tissue disorders, they are atherogenic. So that is also predisposing a person. If the person is having nothing else but rheumatoid arthritis, so he or she will be at a chance of dyslipidemia, plus the drugs which you give will also lead to some amount of dyslipidemia. So that is why the importance in such a scenario to control weight, to keep doing lifestyle intervention and keep reminding the person at every visit they come to do it. And premature menopause. Premature menopause, it is said that at by 35, if some women has menopause, that is premature. So it is not good because the protective effect of estrogen is lost. So premature menopause itself will put a person at risk. And preeclampsia, diabetes, we have already mentioned. Why PCOS? PCOS is also associated with inflammation. There is obesity and hormonal imbalance. So dyslipidemia will be there here also. Then air pollution, polygenic inheritance and HIV infection. The drugs itself as well as the disease can affect. So now previously people with HIV were dying out of opportunistic infection. Now with the advent of ART, what we have seen, they live a very normal life like all of us. And looking at them, we will not say that they are having any infectious disease because they are healthy as we are. But now what they are developing is, or what the trend is, that they have this lifestyle disease now and they also have started developing dyslipidemia, diabetes. So that has become a comorbidity for them now. Then when you identify all this red, blue, green, we might not be able to remember a lot of it. What we are trying to tell that in low risk, you have one major ASCVD risk factor. In moderate risk, you will have 2. What was the major risk factor? The first column of 4. Any 1, it is low. 2, it is moderate. More than 3, high. And with more than 3, end organ damage or a calcium score high, or somebody having a atherosclerotic event in the form of a CV, a heart attack, a peripheral arterial disease, or even a non-obstructive thrombus in the carotid, that itself is a risk factor. So as you ascend with more than 3 major risk factors, then the category also increases. So what is important is, it is said that you have to treat everybody. And one treatment which is common to all of them is lifestyle intervention. And that is the cornerstone. It is not just a drug that we are relying. So every system of medicine, one thing which is common to all of us is lifestyle. We might have different drugs to treat. Our aim is the same, but one thing which is common for all of us is lifestyle intervention. And that has to be reinforced at every visit the patient comes to us. That is the importance of knowing all this. When to treat, we say that mild, low risk and moderate risk group, anybody who comes with a dyslipidemia without any other major risk factor, then you can ask the person to do lifestyle intervention and repeat the sample after 3 months and see. If it is a moderate risk, you advise lifestyle intervention and you start the statin, the drug which we use to treat dyslipidemia. There is something written as MIS and HIS. Somebody would want to know what is that. It means moderate intensity and high intensity statin. Does that mean that I give a very high dose of statin or a very low dose of statin? Actually, it does not mean that. What we are trying to tell is, when you give the statin, your goal of reduction of dyslipidemia or LDL, if you expect that low intensity statin means by the time you repeat the test, you expect a 33% or 30% fall, then it is a low intensity statin. If you're wanting a fall of 30 to 49%, then probably you're aiming at a moderate intensity statin. And if that drug dose causes a fall more than 50%, then high intensity statin has been given. Okay, so for a rosuvastatin, it can be 20 moderate, and for atorva, it can be 40, and high dose can be 80. The drug dosage is not what we are trying to tell. It is the aim to reduce the dyslipidemia, which tells whether it is a moderate intensity statin or a high intensity statin. And if still it persists, you keep adding the other drugs accordingly. Then what is important is, from high risk to extreme high risk, everybody has to be initiated treatment. That is what we do, that everybody's, but lifestyle intervention is there. It is not held behind. So everybody with dyslipidemia, lifestyle intervention has to be done, and they will be started on statin. And week 0, we have calculated the percentage reduction. We want a 50% reduction in statin, and this reduction will also depend upon the other risk factors which are present. For example, somebody with a diabetes, no end organ damage, but with a dyslipidemia, normal 100, you are saying that LDL is normal, but in such a scenario, we'll want it to be 70. And if somebody is having an end organ damage, we will want it to be 50. And if somebody has had a atherosclerotic event in the form of a heart attack or a peripheral arterial disease or in the form of a stroke, then we want it to be 30. So targets keep coming down as the disease worsens. The most important thing here, till extreme category B, we have mentioned there is something called as a category C. So that I will want to highlight. What is category C? Somebody who's had an event of heart attack or any of the atherosclerotic event, on lifestyle management, on maximum possible drug, and with good lifestyle intervention, still keeps on having heart attack or the same event again and again, then he is extreme. So extreme category C. Now there the goal of LDL will come down even more. We come down to 10 to 15. So that is the importance. These are the targets. So last thing, 10 to 15 is the LDL target, as I mentioned. As the comorbidity keeps increasing, your target keeps coming down. So 30 was good enough, we thought. But if somebody, or despite maximum possible measures from your side and from the patient's side, still keeps having, lower the LDL targets more. That is what is newer. When I was studying initially, it was 70. Then by the time I started practicing, it became 50 and now 30. And so the targets keep changing. Only thing is, we are trying to reduce the risk as much as possible. Okay. Then another thing which we want to tell is metabolic associated, dysfunction associated steatotic liver disease. All of us will be knowing it, the previous name, NAFLD. non-alcoholic fatty liver disease. So there was a name change. So why a name change? When we mentioned fatty, it produces a stigma. Fatty liver is there, very right. And when we say somebody, oh yeah, he's looking fatty, so that brings a bad this thing. No, so one, the stigma with the name itself, and the other thing was the name says it is non-alcoholic. Then somebody will say, then you define what is an alcoholic. So a patient comes to the clinic and he says, I drink alcohol only when I go for a wedding or a party, and that too once in a year. You call me alcoholic because I have tasted it. So is it possible? No. So you want the person to be a teetotaler? That is also not possible. So you have to consider everybody. So here it is that somebody who has hepatic steatosis, which is more than 5%, it is histologically you will be telling it, and at least one cardiometabolic risk factor. I'll come to what cardiometabolic risk factors. Then with no other underlying cause, that is, it is not that he is a chronic alcoholic and because of that he has developed CLD, or he has no other infectious disease which has led to CLD, with minimal or no alcohol intake. What is minimum? Less than 20 grams for a woman and less than 30 grams for a man for 10 years, over 10 years period per day. If he has taken less than this, then you can label the person a non-alcoholic. If such a scenario occurs, then it is called as metabolic associated steatotic liver disease. And if somebody is having, then the first degree relatives have a high chance of developing. Okay, as madam mentioned, it is called fatty liver. She's very right. If half of us get ultrasound now, many of us will be there, and it is not just depending upon the how we look. If we are slim, that does not mean. It is about visceral adiposity that is playing a part. Okay, so the cardiometabolic risk factors which we were going to talk about were excess of adiposity. So BMI more than 25. But the catch is there that for us it is not 25. We have to come down. At 23 and beyond, we are overweight. So for our population or the Asian population, being overweight is at 23. So by that standards, we are all overweight, most of us. So the importance that we reduce our weight also and our patient's weight. So waist circumference, I'll talk about the South Asian. We have already mentioned 90 centimeter for a man and a woman. It is a bit different for Japanese. It is 85 in men and 90 in women. Then diabetes. As I mentioned, diabetes itself causes dyslipidemia. Diagnosis of diabetes as well as a diagnosis of a pre-diabetes. Both are going to be risk factors, cardiometabolic risk factors. For pre-diabetes, the HbA1c value is 5.6 to 6.5. If it is falling between these, then also the person is at risk. That is pre-diabetic. Then hypertriglyceridemia. Dyslipidemia itself is adding, and here to the disease also, metabolic syndrome diagnosis also, dyslipidemia will come up. So more than 150 milligram, or somebody who has a controlled value of triglyceride but on a drug therapy, that is also a cardiometabolic risk factor. And high density lipoprotein, HDL levels lower, that also is a risk factor. Then arterial hypertension. We mentioned that for dyslipidemia also in ACVD also we are talking about the same. So as I mentioned, they are like 5 fingers of our hand. The metabolic disorders move together. One is there, the other will come. All we can do is reduce the risk factors which are within our hands. Okay. And then arterial hypertension. Somebody who is having hypertension or controlled blood pressures on drug therapy. So that is also a risk factor for metabolic associated liver disease. Then what can be done? I'm saying lifestyle modification from very long time, so it is going like a drab thing. But I'll tell what we mean to say by that. We want weight loss. How much? The moment you tell weight loss, the person will ask, how much should I lose? The patient, the first question they will ask. So from baseline, 5 to 7% you have to lose. How fast should I lose that it becomes all right? It is all Swiggy Blinkit times, 5-minute delivery. So patient also wants everything in 5 minutes. So how fast? So it is said that you lose weight 1 to 2 kgs in a month. It can be a slow weight loss, but it has to be steady weight loss. It has to be a loss, but slow. It is all right. So we can reinforce that the person will come, I have done everything, only half a kg loss, doctor. What should I do? Very good. Half a kg, next month you come, it should not increase, and you try bringing another half kg loss. That is all we can do for the patient. And how do you advise weight loss? What lifestyle intervention? What should I do? I am walking in the park every day. The people will tell, I am doing walking every day. So what we have to do tell is 150 minutes of exercise in a week. That amounts to 30 minutes of exercise for 5 days a week. But I don't have time. That is the biggest constraint for us and also for the patient. So it does not mean that you have to do the exercise of 30 minutes in one go. You can divide it over the entire day. It can be 15-minute sessions twice in a day. It can be 10 minutes according to the patient's convenience, but it is moderate intensity. So how do you define moderate intensity? Moderate intensity means when you start walking, you can talk to the person walking next to you, but you cannot hum a song along with it. You cannot have conversations, you cannot gossip, because that requires slower this thing, and you want to talk in full sentences. You can talk in 1 or 2 words when you're walking fast, moderate intensity exercise. Okay, so you cannot sing a song, but you can talk to the person, your heart rate should increase, and by the time the exercise has started, you should start sweating. There should be some light amount of sweating present. So that tells the intensity of exercise. So all of us, what we generally do is a leisurely walk. That is not moderate intensity. So that is why our patients are not losing weight. Okay, so that is one thing that we have to remember. Other way of doing a moderate intensity exercises can go for cycling. Somebody wants to do swimming, that is good. Strength training exercises are good. Why strength training? Just losing weight is not important. You have to prevent loss of muscle. So sarcopenia is a phenomenon that occurs with the metabolic diseases. Sarcopenia means your muscle mass is being lost. So that is harmful. When the initial weight loss begins, you lose fat, but you lose muscle also. To prevent that muscle loss, you have to do exercise. And that exercise has to be a strength training exercise that will help to retain your muscle mass. The more the muscle mass you have, your basal metabolic rate improves. So baseline, even if you are not doing much of an exercise, that muscle will take some amount of energy and will keep burning calories. So that will help you maintain a weight loss. So the importance of doing a strength training exercise. So this is the lifestyle intervention that we can tell our patients. Okay. And then abstinence from alcohol. It is not key you can have little bit once in a while. No, there is no bargaining on this. Abstinence is abstinence. So you have to tell for sure that you have to stop taking alcohol. Then there are drug therapies. Vitamin A, UDCA is ursodeoxycholic acid. Resmetirom is one of the newer drugs that has come up now. It is costly. And GLP-1 agonists and diabetic drugs, these cause weight loss, and they are also helpful in diabetes and weight loss, also in metabolic diseases. So this is being used by us. So obesity. Of all this waist circumference we mentioned, so obesity itself is now, it is not a risk factor. Obesity has become a disease. It has risen to pandemic proportions now. What our parents' generation or probably grandparents' generation, they ate well, and we say that they ate everything and still they were, because the amount of work or the amount of exercise in the form of moderate or high intensity exercise was what they were doing. The amount of labor they were doing in the fields without the help of equipments made them to do exercises which, so they did not need to find time to do an exercise. So obesity has become a pandemic now. So, and why it has become a pandemic? Because of the overnutrition, easy access to food at odd timings, and the sedentary lifestyle. So that is one reason, and environment and genetics is also playing a part. What is the importance of knowing about obesity? It has association with a lot of things. It is a state of chronic inflammation. Inflammation where? In the vessel wall. And that is what is happening in your hypertension, your dyslipidemia, and diabetes. So it is atherogenic, or it is also bringing dyslipidemia. Chronic inflammation will ultimately affect into hypertension. It will lead to fat accumulation, diabetes. The end point is that we cannot talk of one without talking about the other. We cannot control one without controlling the other. So they are like, we don't know whether the egg came first or the hen came first, but they are there and we have to control both. So how do you do strategies? As we mentioned, exercise, bariatric surgery, that is mentioned, but do we advise bariatric for all? No, we don't advise bariatric for all. It is for BMI more than 30. 35, but even before doing a bariatric surgery, the patient is motivated and is expected to lose weight, some amount. He might not be able to lose a lot, but the person is asked to lose weight. That shows that there is motivation to lose, because it is not that the surgery you have done and it is absolute. Surgery has its own complications, plus they might gain back the weight if they come back to their previous eating habits. So the importance. So it is not that on the first go bariatric is advised, no. Lifestyle intervention, Then obesity, there are a lot of drugs, but the most important thing is diet and exercise. So it seems to be easy when we are talking, but this is the most difficult part of management of a metabolic disorder, diet and exercise. Then gout. Gout, all of a sudden, why an arthritis when we are talking about so much, right? Gout is a chronic inflammatory disease. And if we look at an obese person, their uric acid level will be higher as compared to the normal. So that itself is telling uric acid elevation tells about excreted by the kidney. Chronic hypertension, in hypertensive you have a higher uric acid. Obesity it also is causing the same thing. So the importance of knowing this disease. Who will have gout? Generally men, elderly, and in women postmenopausal age group. Why postmenopausal age group? Because estrogen again has a protective effect. It helps in uric acid excretion via the kidney. So a higher value of this thing is kept for a woman to be diagnosed with gout. Generally we all know it is a monoarticular disease, one single joint, mostly the great toe will be inflamed. It is extremely painful. Do we treat it? Yes, you have to treat the acute event of gout. We give painkillers, and depending upon the comorbidity, kidney disease patient and all, you can give steroids. Then it has to be given at least 7 to 10 days. What important thing which I'll want to tell is, if we look at the risk factors which is within our control, the left hand side, the entire thing which we spoke earlier is there. Again, diabetes, obesity, hyperlipidemia, cardio. Overweight people are at a higher risk. Men and women equally, irrespective of menopausal status. So, if we look on the left hand side, this is what we can control, and this is what is difficult to control. So, the importance of knowing about gout. So, dietary advice in gout, red meat, we will tell them not to take. Red meat has to be avoided. Corn, starch, starchy, syrupy things, which is very easily available in our fast foods, that has to be avoided. And where do we find corn starch? Even the muesli and all, which is said to be a good diet food, they are sugary, they are sweet. So the sweetness is coming from cornstarch. So cornstarch syrup. So that has to be avoided. So seafood also, very good. Seafood also, madam, you're right. I forgot to say that, right. Seafood is also there. Leafy vegetables is also this thing. Anything with a high purine content, low fat dairy can be taken, not high fat dairy. So that is one thing that we have to advise. You can take a lot of fruits. Fruit juices are to be avoided. Does that mean the juice which we take out at home? Juice of any kind, whether preserved or you're taking out the juice at home and preparing it fresh, any juice. So you can take the fruit as a whole. So it will provide you fiber, it will provide you complex carbohydrate. So you will be satiated, it takes time to digest it, and the purine thing will be less. So red meat and organ meat, not just red meat, even people like having that chicken liver and mutton liver, goat liver. I think karal is what it is called, right? If I'm not wrong, right? Okay. So that thing is a delicacy. Even I was a student when my friend used to bring, I used to love it. Okay, but then that is a thing that we have to avoid. So red meat and organ meat, that has to be avoided, and alcohol. So now if somebody asks alcohol to be taken, no moderation, it is to be stopped. Then treatment part, as I mentioned, acute has to be treated. NSAIDs or painkillers is what we generally give. Depending upon the comorbidity, we do give other drugs, for example, colchicine or a steroid. 7 to 10 days you will have to give it for this thing to come down, the inflammation to come down. It is extremely painful. The person will not be able to walk. You will not be able to touch the joint itself. Generally monoarticular. Sometimes it can be polyarticular. But do we reduce the uric acid level for all? No. If you have more than 2 episodes of gout in a single year, then probably we do start the patient on a urate lowering therapy. And if the gout crystals, the monosodium crystal starts depositing into the joint, then that is called as tophi. If that is a scenario, we give a urate lowering therapy. And also if there is kidney disease, stones in the kidney, urolithiasis, kidney stones, if that is there, then or a uric acid level more than 9, then we definitely give. But somebody on a urate lowering therapy, if he or she develops gout, you do not stop the therapy. You continue with the therapy and you treat it like an acute gout. So if you are already put the person, like we give febuxostat and allopurinol, if the person is on that and has developed gout, we do not stop those drugs. We ask them to continue that and we treat it with the NSAIDs. And weight loss again has to be done. The moment you start losing weight, the uric acid starts coming down. So that is also important. So thank you. If any questions you will want to ask. Inflammation itself is affecting your liver, and the lipid metabolism also happens in liver. Endogenous lipid metabolism happens in liver. So that inflammation, when it affects, the clearance is not there, so it starts depositing. So fatty liver happens, and in uric acid and gout also, it is a chronic condition. Inflammation will be there. Plus, as I mentioned, certain drugs which we give, that also will affect dyslipidemia. I mentioned giving steroid. Steroid produces dyslipidemia. But does that mean that I do not use a steroid? It has to be used with caution. It is, excess of everything is poison, but if not in excess and in the right doses, it is good. So that is why it causes. Somebody asked something else. Hanji? Yes. There's a shift in cycle. The cortisol level, the stress hormone cortisol, it will shift. So normally in the night you have less of cortisol. You are not in a flight or fight mode in the night. You are resting down. So the cortisol level comes down. That is the normal physiology. So, but when you become a night worker, you want that cortisol in the night because you are awake in the night, and for you the day is night time is when you come down and sleep. That is in the morning hours. So your circadian rhythm will change accordingly. So that is whatever it is you do intermittent. It is not time restricted. It is the calorie restriction that is important. You eat it over the entire day. You have 3 meals, controlled calories, or you have 1 meal or 2 meals within 8 hours, but the calorie is controlled. You will lose weight and you will maintain your dyslipidemia profile. So intermittent fasting, actually why it helps is, for some people, is the window to eat is less. So how much can you eat in that small window? That is probably, but it need not be necessary. So will you ask me to advise intermittent fasting somebody? It does not work for the same for everybody. So I will, it is, what is most important is a calorie restriction. Time restrictions, more than time restriction, calorie restriction is what will help.
When we listen this,
You can receive the facts and store for a short time the recent memory, because the prefrontal cortex and the parietal cortex holds it for a very short duration of time. But for you to have it there in the back of your mind, in your frontal cortex, you have to repeat it again and again. So that is why I mentioned that every visit the patient comes, the patient will also be irritated. The doctor is only telling weight loss, weight loss, weight loss. But since you're telling it every time, there will be a constant nagging in his mind. Oh, next time also if I go, he will say weight loss, and he's not, probably he'll scold me. So that helps. Huh? No, he will not change the doctor. He will not change the doctor. No. They know. The more you talk to them, the more you give time. So that is more important to them. They will not. They want to talk to a person who wants to listen to all their queries, not get angry, and still tell them the same thing. Exactly like what our parents keep doing to us. We are angry, but we don't change parents. So patients also don't take doctors. It is very difficult for them to change.